Hello everyone, I'm Dr. Taskeen and I welcome you all on Homeopathy Musing. First of all, I would like to wish every one of you a very happy World Homeopathy Day where we celebrate the legacy of Dr. Samuel Hahnemann and the profound healing art of homeopathy. And on this occasion, our session for today will be on integrative approach for management of neurodevelopmental disorders. And we have with us our honorary guest, Dr. Praful Barvalia, sir, who will be joining shortly. We have Dr. Preeti Shah, who will be talking about this neurodevelopmental disorder. And we also have Ashwini Deshpande, who is a clinical psychologist who will be throwing some light on the integrative approach to management of these disorders. So, before starting, I would like to quickly brief you through the upcoming session on homeopathy musing, the ongoing and upcoming session. So we have the full spectrum pediatric course that we've started already. It is a 12-session course and we aim on covering every aspect of the pediatric care. And if in case you are interested, the recording for the previous sessions will be available. Apart from that, we'll be starting from classroom to clinic course, which is specially designed for students, new practitioners, and homeopaths. Those interested, this will be a 12-session course, and we'll be starting in May. I'm glad to announce another special course with Dr. Dinesh Chauhan, sir, where sir will be teaching the higher order Gentianil and how to explore it through the APG4 classification. The registrations are open for the same. It is a 2-session course, which will be starting in June. We have another course on anxiety and panic, a 360-degree approach, which will be taken by Dr. Aradhana Chitra ma'am. And she will be covering every aspect of the management of anxiety and panic in this course. This is a 4-session course, which registrations has already started for the same. We have Lanthanides with Dr. Jonathan Hardy, sir, and he'll be taking 4 sessions as well. The early bird will be ending soon on the 30th of April, so you can avail the early bird offer. Most of you might be aware that we've recently launched our website, and as a special perks and benefits for our participants, we've started the Musings Corner, where we will be after paying a fixed amount, a minimal amount for a year, you can avail the following benefits. We also, as a part of this perk, we have a monthly hybrid session. We recently have had a hybrid session, and we'll be discussing cases in these hybrid sessions. Apart from that, I would like to announce another course, Practical Application of Homeopathy in Psychotic Disorders, which will be taken by Dr. Preeti Shah and Dr. Prajakta Vaidya, 2 sessions in September, and a special offer for today, World Homeopathy Day. Any 30 participants will get 30% off on this course. So you all can register for the same. If you have any questions, queries, or difficulties, you can always write up to us and we'll be happy to help you out. I'll stop sharing and I think we can start with today's session. I would like to invite Dr. Preeti Shah, ma'am, if she can come forward for today's session, and I'd like to hand over to her.
All right. Hi, everybody. Thank you, Taskeen, for the warm introduction and welcome. And hello, everybody. Very, very happy World Homeopathy Day. Let's celebrate the beauty of our science and what it offers. The potential of this gentle healing modality to change the world, to change lives, to change individuals, and For me, especially, homeopathy is no longer just a profession. It's no longer something that I do from 9 to 5, right? And it's no longer just applicable in my clinic. It's a way of life. It's a way of things, how we perceive life, you know, how the law of similars is not just applicable to the medicines or the remedies we give, but to life itself. Yeah, it's a way of, it's so closely related to even spirituality. I think it's a very, very beautiful science. And no wonder it's not just science, it's also artistic. So, on today's session to celebrate homeopathy, to celebrate Prajakta and my journey, especially with the musings community. We started musings roughly 5 years ago. On this day 5 years ago, we did our first webinar. Um, and that was per se, the inception, so to say, of musing. So it is special for us in many, many ways. And I don't know, Prajakta, if you wanted to say a few words before I start sharing my case and slides.
No, I think feeling very nostalgic, and I think this journey of 5 years, and before that our practice. So I think this has been become a part of our life, as you said. So it's not just a profession or a career or a work. It's like it becomes a part of your life. It is what you are, and then you give what you have. So it's constant, you are evolving yourself in terms of your knowledge, in terms of your skills, in terms of you as a homeopath and as a physician. And I think this has been a wonderful journey. That's what I feel if I look back and when forward also. There's so many things that are and new opportunities, I think, that will come. So very excited about that.
Yeah, and I just wanted to thank each and every one who were the building blocks for this, right? Asmita, Catherine, Dr. Taskeen, Dr. Mansi, and so many other doctors before them. We build this community with your help, with you, um, and also so many supporters of musings from all over the world. I wanted to also specially mention Dr. Reni, Dr. Channa, Dr. Jyoti, the blessings of our teachers, Dr. Gandhi, Dr. Sankaran, Dr. Jayesha, Dr. Shekhar. The list is so long. I may even forget some names and I'll feel so guilty about it. So, everybody, thank you for your blessings. Thank you for being part of this journey. And thank you for practicing homeopathy, seeking homeopathy, coming here. And despite your busy schedules, to know more about homeopathy, learn homeopathy, share homeopathy. It's wonderful. Today, what we'll do is I will share some thoughts and cases. Perhaps Prajakta may share her cases if we have time. We'll have Dr. Barvalia join us very shortly. So he's going to speak about the tremendous body of work he has done, especially on neurodevelopmental disorders. And then we have also invited a special guest, Ms. Ashwini, who's going to speak about, she's a psychologist, and how we can work as homeopaths in collaboration with them in healing and changing lives of these children and these children who grow into adults, right? So autism spectrum, ADHD, so many of these disorders. Uh, we had the World Autism Day very recently, right? So we thought it's going to be an interesting way to speak about both homeopathy in its role as well as how we can help these children a little bit better. Okay, so with that context, let me go ahead and share my presentation. Before I go into the case, I just wanted to very briefly speak about the neurodevelopmental disorders in general. And I know that some of you are from classical homeopathy, uh, uh, you know, some of you who perhaps are new to a lot of these contemporary techniques in homeopathy that can be used in healing neurodevelopmental disorders. So I'll spend, let's say, 10 to 15 minutes just to give a little bit of background on how we can use both our left and right brains to better heal these patients, and how some of these newer approaches can assist us, how some of the new maps can assist us in healing these cases. Okay, so what are neurodevelopmental disorders? These are conditions that affect the development of the nervous system, particularly the brain, right? So these are group of disorders, these are group of conditions that are characterized by some form of disruption to the typical brain development. Okay, and basically because it's a group of disorders, uh, it's a conglomeration of various clinically the symptomatology, the presentation of these can be varied, right? There are individuals with intellectual disabilities, disabilities or disorders that can affect communication pathways, for example, the autism spectrum, then about focus and hyperactivity, like attention deficit hyperactive disorder, learning disorders, motor disorders. So there are varied, set of disorders which are all being clubbed together because they all affect the neurodevelopment of the nervous system, right? The development of the nervous system is somehow affected, and that then has impact on its functioning, on cognition, on behavior, on social interaction, communication, motor skills, whatever. A lot of them, a lot of these group of disorders come with challenging behaviors and psychiatric illnesses. A lot of them come with difficulties in, social behavior. They come with, feeling left out, feeling unable to cope with the day-to-day dynamics of life. And hence, a more holistic therapy like ours, like homeopathy, can help them because it's not just, physical, or it's not just neurodevelopmental or endocrinal or immunological. It's the entire psycho, neuro, immuno, endocrine axis, right? So, of course, we all know this, but just to set the stage, the causation could be varied. It could be prenatal, perinatal, environmental. It could even be genetic. It could be due to some hypoxic damage at the time of the birth or during pregnancy, or it could just be simply neurotransmitter imbalance. So the cause of these disorders could be varied, and the presentation, as I said, could be completely different. Yeah, there is a separate subset of NDDs which are communication disorders, which is to do with language, which is to do with speech and sound, which is to do with, for example, stuttering. Or there could be specific learning disorders, which could be, focused on only, let's say, mathematics, mathematics inaptitude for. So it could be varied, and all of them, are clubbed together under this bucket of disorders. Okay. And yes, as homeopaths, we have a very, very definitive role to play. A lot of the children suffering from these disorders, need integrative approach. Yeah. So along with, not just special education, not just OT, not just counseling for the parents, not just behavioral therapy, speech therapy, but homeopathy alongside can make a huge difference to these children. So, how do we approach these cases? Of course, we need to do a very detailed, like any other disease or like any other case, we take a detailed case history. We understand the child, take its complete medical history, past history, birth history, vaccination history. We understand also the child's physical particulars, physical generals, mental generals. We observe what's happening, how the child is behaving in the clinic. We also inquire about the interpersonal relationships and dynamics of the family and the child. So we also explore the child's immediate environment and try and understand how it is affecting the child. Uh, and finally, as with any other pediatric case, we need to look at the mother's history during pregnancy. So that's going to be very, very critical. To remind you, a lot of these children who have behavioral issues, who are hyperactive, a lot of children with spectrum disorder are very hyperactive. They have a lot of other issues. They're given very, very strong medications in the conventional school, yeah. Uh, and a lot of them are drugs or medicines that are also given for severe health conditions. Yeah, a lot of them receive anticonvulsants, a lot of them receive SSRIs, a lot of them also receive antipsychotics. So sometimes it may be needed. Sometimes these children are already taking these medications before they come to us. So we may not be able to stop them. Some of them may need simultaneous therapy with allopathy and homeopathy. But as the homeopathic medicines take role and is able to start acting along with the developmental pediatrician or the treating psychiatrist, we should slowly be able to taper these medications under their supervision. Some children who have not started these medications, if they've come to you directly as homeopaths, perhaps the need for these medications is, is completely eliminated, delayed, or are on very, very low dosages of these medications. Yeah. So just as a reminder, what are you offering? And what are you offering as an alternative to what is currently available out there? Yeah, this is very, very important for all of you to know. Now, before we go into some cases, I just wanted to introduce you a school of thought which is helping us in understanding the inner age of our patients. Now, this idea is applicable to any cases that come to you. Yeah, it could be pathological case, psychiatric case, it could be neurodevelopmental case, any case. This idea is applicable everywhere. I'm just going to try and focus on the practical utility of this method or this idea or ideology in NDT cases. So first of all, what is inner age? Inner age is something which is different than our biological age. Yeah? You could be 60 years old, but you say no, that, at heart, he's still a child or he's still a teenager at heart. So what we are trying to understand is what is the inner, what we are trying to map in the personal evolution model that Dr. Mahesh Gandhi has spoken about is the inner age of this individual. And this idea comes from Erik Erikson, who was a neo-Freudian psychologist who developed a psychosocial developmental axis. So, he spoke about series of stages that every individual undergoes as he develops from his infancy to adulthood. And at each of these stages of psychosocial development, individual learns certain psychosocial developmental skills. And if he's able to develop those skills, he's better equipped to go into the next stage. And if he somehow gets stuck there, then that's when the issue comes. So what are these psychosocial developmental stages that Erik Erikson postulated? He postulated 8 stages, starting from infancy. What Dr. Gandhi did and what this model explains is an additional 9th stage. And the additional 9th stage is that of womb stage. Yeah, and all of us know about it. We have heard it in some forum or other, right? So one is the womb stage of development, which is even before infancy. So I will skip the womb stage, but just to show you what's Erik Erikson postulated. He first postulated the stage of infancy. That means at this stage, the infant needs to develop the main skill of trust. And if he is unable to develop that, he's going to lifelong struggle with mistrust. If an infant is well cared for, he or she will develop faith in the future. And if somehow the infant is unable, if he doesn't get the love, the care, the nourishment, the protection from his parents, from his primary caregivers, then he gets stuck at this stage of development. The next stage of development is that of toddler, where the main idea is to the development of autonomy versus doubt. So at this stage of development, it's the first time the child is able to do, you potty train the child. It's the first time that he's going to try and walk a little bit, bobble, but walk independently without support, for example. He's going to develop self-control. He's going to develop self-assertion. He's going to develop autonomy, first independent steps. And somehow, if the child gets stuck here, he's going to be confused, doubtful, lack of confidence, and that kind of things. The next stage of development is that of initiative versus guilt. Here, when the child begins to make his or her own decisions, constant discouragement or punishment will lead to guilt and the loss of initiative. Then is the stage of school age, where the main idea is to develop industry. The main idea is to go out, have homework, understand what is right, what is wrong, understand, okay, what is my role? I need to succeed. I need to come first in sports. I need to do this and I need to excel in academics, etc. So he needs to work hard. He needs to study. He needs to have a timetable. He needs to carry that huge big bag and go to school. And somehow, if he gets stuck here, he will develop a sort of inferiority complex. Then comes the stage of adolescence, where the idea is, what is my role, in this group? How can I develop my own separate identity? What career I will choose? How I will fit in? How I'll follow the trend? How I will be different, or how I will not follow the trend? How I will not follow the rules? How I will rebel, etc. Right? So here the main issue is identity versus role confusion. Then is early adulthood, where you develop the main skill of intimacy, personal one-on-one relation versus isolation. Then you work hard, take care of your family, save for your future generations. So the main idea is generativity versus stagnation. And then finally late adulthood and old age, where you end up with despair, etc. So on this model, without going into a lot of detail, the idea is, using this model, we are able to, during our case taking, understand how developed this individual whose case we are taking. We do the entire case taking, we take the whole history, we follow each and every step, but we keep a zoom out view to see that, okay, even in his childhood, even right now, even in his dreams, in his personal relationships, in the career he's choosing, in the hobbies this person has, what is his inner age? How developed is this individual? Is he the individual extremely clingy, underdeveloped, timid, etc.? Or is this individual, very, very obsessive, trying to be very perfect and trying to keep control all the time? So you are trying to keep a zoom out view, like a bird's eye view, and understand at what stage of development this child is. So even in neurodevelopmental disorder cases, you try and take the entire history, but try and understand how developed this child is internally. Yeah, and understand, is this an old man with a young heart, or a young boy with, who's an old soul? So once we do that, this way we are able to narrow down a group of remedies that perhaps can help in these cases. Okay. So for those who follow or have some background of the sensation method, or those who understand the mineral, chart, Sholton was the first who populated, he used the periodic table and kind of compared it with homeopathy and how homeopathic remedies from the mineral kingdom work. If we just look at that periodic table, we see that the lot of remedies in row 1 and row 2, lot of remedies perhaps also in column 1 or column 18 are the remedies that are frequently prescribed in neurodevelopmental disorders. For example, a lot of remedies also in row 3. If you are from ICR school, or if you know that frequently for autism cases, how many autism cases we have given natrum mure, we have given phosphorus, silica is so very well indicated. So if you see these upper rows of the periodic table, the initial few columns and the last column of the periodic table are more indicated in these cases. If you look at the plant chart, this is the plant chart. This was first developed by Yakir. Yakir uses the Cronquist classification. It's the botanical classification of, which uses the Cronquist method, where the plants are classified into different groups based on how they evolved. Yeah, so which plant came the first and which is the most developed or most recently developed plant. So in that order, these plants have been grouped and classified. So using that, if you see, when you look at the plant chart, and if you understand that with an inner age perspective, so the plants and families belonging to the left side of this chart, and plants and families belonging to the womb stage of development, which is this first row, they are more frequently, more frequently um, indicated in these cases. Okay, so for example, remedies like magnolia, remedies like nufar, remedies like, for example, belladonna, hyoscyamus, stramonium. These are the cases that are more frequently prescribed. Remedies like pulsatilla, very frequently prescribed. Remedies like opium. Now, so all the remedies from the initial column of the plant chart and the womb stage of development, which is the first row, the womb stage of development of the plant. Similarly, if we look at the animal chart, this chart was developed by Dr. Mahesh Gandhi. If we look at that, we see that again the same idea. The remedies which have very low development, yeah, that means are on the left side of this chart, are more frequently indicated in the animal kingdom. Remedies, for example, mollusks, they are more frequently indicated in these cases. Another group of remedies that are very frequently indicated in these cases are certain lack remedies. Yeah, so remedies like dolphin, for example, very frequently indicated. Remedies from the primates group, which is the monkey group, they are very, very frequently indicated in these cases. Okay, so this is just a little bit of an introduction, like a precursor, if like a trailer, if I may, to how we could use this right brain approaches, these different charts, in coming to the correct remedy. It is not a bypass. It is not a shortcut to what we are doing. We will still take a complete detailed history. We want to individualize these cases. So we cannot say all cases of ADHD, give them tuberculin, that's it, end of the story. We cannot work like this. We have to individualize, find the PQRS, take the complete totality. But as we use repertory as a tool, these charts and these right brain approaches are another way to kind of navigating, shortlisting certain group of remedies and coming to the simillimum in these cases. I'm going to pause here and see Taskin, if we are ready for the case, or do we have Sir here already? And we want to first bring him up.
Yes, ma'am. Just sir has not joined yet, ma'am.
Okay, so then let me go ahead and continue with the case.
Yes.
Before I start with the case, are there any quick questions? All right. If no, I will go ahead and share my case. So this is a case of a young boy. He's already diagnosed on the spectrum, and along with the spectrum, he has ADHD. Okay, when he came to us, this child was 3 years and 8 months old, and you'll have to just give me a moment. Yeah, and when he came to us, the primary complaint the mother had was delayed speech, hyperactiveness, uncontrolled anger, and sensory vestibular issues. The child was getting treated by some other homeopath. The child was receiving Baraita cup. This is also another way that, a lot of homeopaths practice, and, it's not really necessarily individualized. It's with some preconceived notions. So uh, we need to, avoid using those kind of shortcuts. So we try and get the history from this mother. The mother says that he constantly says wow. He makes sounds of animals. He copies us. He never sits in front of the camera. Okay. He's very aggressive. He's hyper. If he sees something he doesn't like, then he would want to switch off the TV. Then he will come to bite. Yeah. So if he wants to do what he wants to do, uh, he doesn't sit at one activity. He wants to explore things all the time. He's very aggressive. The child has not developed any eye contact yet. He would bang things, he would throw things, he can hit you. He's very, very impatient and he wants everything quickly. Another area that the mother spoke about at length is about his um, anxiety. He says, the mother said that the child is very, very attached to her, to his family, to his grandfather, and experiences a lot of separation anxiety. He needs to be with the mother all the time. When he gets angry, he will try and read the room. So if the mother is too angry, he'll go to the grandfather. If the grandfather is too angry, perhaps he'll find the father. So he's very intelligent that way, and he'll figure out whom to go to when somebody is angry. And then what he wants, if he doesn't get, he'll get very stubborn. He will start banging things. It is very difficult to then distract him. You will have to vigorously try and find ways where you distract him with something else. He doesn't like to play with other kids. He chooses to be alone. And then it's difficult to mingle and find ways, where he will mingle with other children at school, in his society, etc. He can hit other kids. If anybody comes near him, he can hit them. He will not run at speed with them. He will not climb on things. He will just be with himself. He will do things if you give him certain instructions. You need to do this, you need to do that. He will perhaps not do it. He will do things on his own terms. He doesn't follow instructions. He doesn't like that at all. In fact, there's a lot of capriciousness. So if he wants something, you have to give him, then after some time, he doesn't want it and he wants something else. His concentration is a little less, yeah. He has been he finds it difficult to sit in one place and do things. He will watch some ads on TV, but if he doesn't like it, he will drag you, he will pull you, come switch it off, come switch off the television. Otherwise, physically, he's been very, from childhood to now, he's been okay. He hardly falls sick. Then she mentioned about some vestibular sensory issues. So we try and explore if there is any individualistic trait, anything characteristic, anything bothersome over there. So the mother says he can't brush his teeth. He has to wear, short clothes. I mean, long pants. He absolutely doesn't like. He will cry. And, sometimes it just hysterical, right? He's not really having tears, but he'll make loud noise. He'll bang things. He'll make a ruckus of things. He'll try and hit. He'll try and come and bite you. And we take time to calm him down. If you put him on a swing and, like other children, he doesn't like it. Overall, if you take him for any injections or whatever, he's pretty comfortable. If he falls, if he gets hurt, he's not like, he's not very sensitive that way. He's very rough and tough. If he falls, he gets hurt. He will keep going, yeah, there's no problem there. All his milestones were a little delayed. He understands things. What he does is he will look at things and he will copy. So how he does is you have to, if you give him instruction, he may not follow. But if you will do it, he will exactly copy that. Sometimes he will also copy how you're telling. Yeah. So it's not just that he is understanding the word and the meaning. It's sometimes like parroting. Sometimes he also copies the technique with which you're talking, if you say a particular vowel in a particular way, he will repeat it exactly that way. He almost mimics it. He mimics the tone, he mimics the gestures, he mimics the way you talk. So this idea of copying and following or following instructions of people through copying is very, very marked in the child. He's scared of loud noises. Yeah, certain sounds like the pressure cooker, or if it's a musical toy, that aggravates the child. He's scared of balloons, especially if the balloon is going to burst. That sound aggravates him. If he sees something on the television he doesn't like that noise, he will go and hit the television. He will get scared of people's faces. Initially, when he was going for any function, we used to be like, it was very, very difficult because he would not be comfortable in, when there are so many people, strangers, etc. If somebody else sings a particular nursery rhyme, if strangers are talking, singing, he doesn't like that. But if the same nursery rhyme mother is singing, yeah, he will be comfortable with it. He flings things, he wants it, then he wants it. The grandparents are very, very pampering, which is the case perhaps with a lot in lot of cases. So, if he cries a little, the grandparents will come and go ahead and give him what he wants. He will fling anything, he will come and hit you. He's very curious. Another thing that the mother said. He's very curious. He wants to explore everything. He wants to find everything. He will try and, it's like if something is there and he sees it for the first time, he'll go there, you see, oh, what is this? He's exploring that thing a lot. And then from one thing to another to another. Yeah. So he's a very, very curious child. He also keeps on jumping. And, like from the sofa to the bed to the floor, then he'll climb somewhere. From there, he'll jump. He's a very jumpy, bouncy child. This is also another thing that the mother said specifically. What are his hobbies and interests? So you see the kind of case taking also. You're exploring every area. And in this exploration of all areas, you will see a lot of symptoms which are very common in these NDD cases, but some characteristic symptoms that are standing out. His attachment, his clinginess, his anxiety for separation. What we also see is this idea of, getting hyper and violent, biting and jumping. Then we see this idea of bounciness and jumping around. We see this idea of copying and mimicking. So you see, you need to keep your eyes and ears open. When you see like more and more cases, you will see certain symptoms are standing out. They are characteristic. And even if it is a common symptom for the disease, if it is there in a very, very high intensity, if that's the only symptom that's dominating the case, we cannot not take it. You should still take it and repertorize. Okay. Then about his hobbies and interests, he loves to draw, pick up puzzles. He loves water activity. He likes to play with water. He can play in water for many hours, sometimes even the whole day. He likes to watch circular objects. Green and red colors are something that he really likes, and he can't distinguish some colors. He can match things. He can go and pick up things that he needs. Some physical generals, he doesn't like sweets. He craves a lot of junk food. He doesn't eat outside food, but only home cooked food. He loves fish, eggs, and chicken. And he drinks a lot of water, and he loves to play in water. Then we explore the mother's history during pregnancy. Okay, so the mother in this particular case was our existing patient. So we knew that, the mother's history and, how she is as a person, etc. And the mother was already doing extremely well on natrum phos. There was no other significant history during the pregnancy. Okay, we tried to explore a lot, but, there was nothing marked. There was no dream, there was no stress, there was no craving that changed during the pregnancy. Nothing significant characteristic came out from the mother's history during pregnancy. However, certain traits of the mother, which I want to share with all of you. One is that as a person, she is very attached to the family. She herself was a very pampered child, something that we also see in our patient. A very pampered child by parents, by husband. She's very close to her in-laws. Yeah. So, her mother-in-law is also our patient. And they're very, very close and bonded and, love each other. Family means everything to her. When anything happens to the family, she gets very worried. And it can be anybody in the family. And then she's unable to sleep and she's praying and she's hoping that, they get well soon. She's very compassionate and helpful, very communicative, very jovial, loves to travel. So you understand why even natrum phos was prescribed, right? You understand certain characteristics in understanding the mother as an individual. So how she deals with the child is also, she loves the child, cares for the child, is very, very conscious of what she's offering to the child, etc., how she's nurturing this child. So my key analysis, what were the key indicators for me? One is I know the label of the disease. But in the very second sentence, in the first time when we saw the patient, the very second sentence in the case taking, and let's see, if I go back my slides, and if you see here, in the very second sentence, he says vows, he makes sounds of animals, and he copies us. So this was very, very significant. And then later on, she said also, right? She said what? She said that he learns from copying, he mimics. So for me, that was it was peculiar, it was characteristic. Then we know this is an hyperactive child. We know he's also aggressive. He throws things, he bites, he bangs heads, right? Then he's also a very curious child, not sitting in one place. Whenever he goes, he wants to explore things, always wants to do something. He's very attached to the family, especially to the mother. Outside, he's not social. He doesn't like to, he gets uncomfortable in parties and social situations. Yeah. But otherwise, with the family, very, very attached. Certain noises aggravate him. Certain symptoms that we can take in the repertory also: jumping, stubborn, copying, imitating. excitement, and difficulties in communication. Yeah, so these were certain characteristics, the building blocks with which, I would want to prescribe for this patient. Any recommendations? What would you do in these cases? Put it on the chat. I see Dr. Chaya is saying lacrisis or delphinum. Dr. Anita is saying looks like monkey family. Dr. Aarti is saying rhesus. Okay, any other thought? Dr. Harish is saying mammal animal remedy. Dr. Karishma is saying lacrisis, jumpy, sensitive to noise, hyperactive. Dr. Mamta is saying phosphorus element is a lot. Rhesus looks like, but so much affinity for water is also lagged delphinium. Also circular motions. Very interesting. Dr. Chino is saying belladonna. Dr. Manjiri lagged delphinum. Dr. Rashmi feels it's a mammal remedy. Dr. Kirti is saying tarantula. Yeah. A lot of hyperactive children, ADHD children who are hyperactive, restless, also angry, violent, aggressive. We often think of spider remedies, no? Dr. Chaya said can be ambra circular motion. Dr. Asmat is saying that delphinum, differential diagnosis phosphorus, sensitive and hyperactive tuberculinum. So very good. I like the thought process. Excellent. So a lot of I just wanted to highlight two things before I disclose the remedy and tell you the analysis. One is the idea that we we take one or two characteristic symptoms that we know, we put it on the repertory, and we come to the same set of remedies. You know, just sensitive to loud noises, hyperactive, we put these two together, tuberculinum. Hyperactive, aggressive, stubborn, hits things, bangs things, tarantula. This is a mistake we need to avoid. Yeah, we need to look at the characteristic symptoms, put it in the remedy. Then see what does the right brain approach say or think about it. Yeah. So does it meet the kingdom? Does it meet the inner age? What is PQRS? What is the myasm? We need to look at the whole picture and prescribe on that. We need to individualize the whole patient to the whole of the remedy, not just one aspect of the patient and one aspect of the remedy. And that's why we would most of the times fail. So I will go ahead and try and complete this case for you. So the remedy that we gave was lac rhesus. We started the patient with 200. I will need to stop sharing and share with sound. Yeah, I have a little video for all of you. So lac rhesus was given, which is monkey. It's from the primates group of the remedy. And I saw immediately, changes in speech, changes in behavior, changes in aggression, changes in the separation anxiety. He was able to go out more, he was able to mingle with children, his focus improved, his eye contact improved, he's playing with water all the time. His OT specialist, speech therapist, they all were able to see tremendous amount of changes in the patient, over a year and a half, close to 2 years, he gradually improved. Yeah. just hear from the mother a little.
Lot of improvement, lot of words coming out now. In fact, he started responding. So if like someone says bye, so he says bye now. So that day by look, I kind of said, like when auntie came to my house and I was like, hi, how are you? So he was also like, how are you? So these, it's kind of the speech is kind of emerging when it comes to like, responding to what someone else is saying. Also, we went to the speech therapist this morning and a lot of words. So whatever she asked him to say, all the words, whatever sounds, he did everything. So there's a lot of improvement in speech. So I don't think that will take any more time now for him to actually start talking because he's almost on the verge of it. And I have felt a lot of improvement now when it comes to aggression and all the other things. It's not there anymore. Like if you shout at him and tell him once, Tiago, stop it, you're not supposed to do it. Initially, like I said, he would throw and all. Now no, he's more scared of us now. So he knows that he's not supposed to do certain things. So that way.
This is another case of, like rhesus that I wanted to show. And it's the same remedy. And this is.
I took an appointment with the developmental pediatric, which she assessed that time 2 years back that he has ASD. So I again went to her for this grade 1 thing only, that where he stands right now on the spectrum. So he's off the spectrum right now, and she has put me off the therapies also.
So you see, just wanted to show and introduce you a new group of remedies which can be very, very helpful. I showed you 2 cases, one completely and just a testimony from another mother where the child was out of the spectrum just with this remedy. Lac rhesus, it's a remedy from the animal kingdom, the mammals group, the remedy prepared from the milk of the monkey. And it's one of a very, very important remedies for this kind of disorders. So that was all I wanted to share with all of you. I wanted to encourage you to learn different modalities, different methodologies that we have in homeopathy, and focus on taking a detailed history, focus on doing a holistic, individualistic, single remedy homeopathy. Okay. And then with that, Taskin, over to you.
Thank you so much, ma'am, for sharing such wonderful case with us. And now we have our honorary guest, Dr. Praful sir, and I would like to warmly welcome sir. And I'm sure sir needs no introduction, but I would like to quickly highlight sir's tremendous work in this field. And yeah, I would like to welcome sir on on Museum's team behalf. Sorry. So, Dr. Praful Barvalia, sir, is a pioneering figure in homeopathy. He's pioneered a holistic research-driven approach to developmental disabilities and mental health, known as Spandan Symphony. He founded Spandan, a government-recognized center for excellence, which runs a hospital and special school for children with developmental challenges. He has led major research projects on autism, ADHD, thyroid disorders, HIV, AIDS, and many more in collaboration with Ayush and leading institutions like TIFR. An international speaker and an academic mentor, he has published over 200 articles and is editor-in-chief for the Indian Journal of Homeopathic Medicine. His contributions have earned him prestigious awards, including the Times Healthcare Achievers Award, Rotary Service Above Self, and Giant International Award, among many. I would like to welcome you, sir, on Homeopathy Musing on this World Homeopathy Day. I'll stop sharing and I hand over to you, sir. Sir, you are on mute. If we can't. Yeah. Give me a second. Can you try, sir?
Yes, yes.
Yes.
Thank you. Thank you, Dr. Daski. Thank you, Dr. Priti, Dr. Prajakta.
Thank you, sir, for coming here. We are so
sir.
happy and honored to have you here, sir.
My pleasure.
So nice to see you, sir, here.
Thank you. On the auspicious day of our founder's birthday, it's a great pleasure. It's an immense pleasure to be with you all. When we are meeting on this auspicious birthday, I would, of course, Dr. Priti, Dr. Prajakta, and all other colleagues have been enlightening you a lot about neurodevelopmental disorders. I will share with you the essence of healing from the standpoint of qualities required in the healer for handling this kind of disorders. There are a lot of articles, a lot of literature, a lot of presentations have been made about it so long and so far. I'll start with the small anecdote. Number of my uh, past students and colleagues may have heard it from in my seminar, but I think it's relevant when I see number of youngsters here. And that anecdote is taking us back into the day of Renaissance, wherein various people in the city of Pizza went to one master architect Donatello with a wonderful piece of marble that, sir, can you make a nice portrait so we can put in our town hall? He looked at it and said that I'm sorry, there are a lot of flaws in this. I can't. They were disappointed. They left. With great difficulty, they had organized for such a huge marble, and they had organized resources so that they can have a wonderful portrait there. But they were disappointed. They waited for years, and a young architect came into the picture, a young sculptor, young artist. They approached him, and that artist looked at the eyes of the dignitaries who had come there. What were those eyes indicative of? There was an eagerness, there was an yearning, there was a plea. They wanted something marvelous. So they requested him, and the artist looked at the piece and then immediately said, all right, I'll go ahead. I'll definitely prepare a wonderful piece of art for you all. He said internally, yeah, it's a big challenge, but no, I'll do that. And what happened next? That in coming months, he started preparing a wonderful portrait from that piece of marble. The stone started getting a shape through the chisel and scalpel of this artist, and within no time, there was a beautiful portrait which was put in the city of Pisa. Now, if you go to Rome, you can see that after centuries, it's a statue of David. Absolutely live, even now, you can see the sharp eyes as if a young David is sizing up the Goliath. You can see a grace, you can see the glory, you can see the beauty. and you can see the life in that portrait. So what happened? There was same piece, and you have a wonderful art piece now. So there are two important lessons as homeopath I learned. One is that before I reject anything, I must look back to myself and try to understand that is it through the dogmatic views I am rejecting something, or I'm underestimating my art and science, I'm rejecting this. And that's how my journey started 3 decades back when I set up the center for the autistic children. Remember, friends, some people were laughing at me, some people were showing pity at me that what are you going to do? You are a brilliant homeopath, are you ruining your career by taking up this? The pediatricians we surveyed, and almost 50% pediatricians weren't aware about autism spectrum disorder at that time. But we moved ahead. We had faith in our science, we had faith in our principle, and we had conviction of teachings of our masters that will be able to translate. Another important lesson for homeopath is portrait. I think this David story, which I may have read in my early student years, when it became alive during this phase, taught me what is the portrait, what our master Hanuman has spoken about it. It is something which is multidimensional, it is something which is live, it is something which is sharp, precise, concise, and it is something which delivers essence. So that is a portrait. And that is the David story said. And that is what our Hanuman has said. When you read aphorism 1, 2, 3, 4, 5, 6, and how you build up the portrait. The guidelines are available to you. That's what my colleague, I think Dr. Priti was narrating to you, that how she built up the portrait. The multidimensional. So the entire experience of handling these challenging cases of neurodevelopmental disorder equips you to build a portrait which is multidimensional. Much more important is it teaches you an important aspect of homeopathic physician, who he should be, the care, the compassion. So unless that you have within, you will not be able to move ahead. The second artist was Michelangelo, who built up this David. And we saw a compassionate personality in Michelangelo. We saw tremendous passion in that artist. And that is what you homeopaths need to develop in order to move ahead. Can I share my screen? Will you permit me?
Yes, sir, I have.
Hope my screen is visible.
Yes, sir, we can see.
Fine. By now we have number of documented cases 123 cases of autism disorder, which we documented, studied as clinical trial, and presented in international conference, the research abstract. But what was a milestone for us was the 60 cases of autism spectrum disorder, which we took under Ayush funded extramural research project, monitored by a multidisciplinary committee comprising of psychiatrists from All India Institute of Medical Sciences. And those 60 cases we studied between 2006 to 2007 and then analyzed and presented the essence of the abstract. And another 96 cases of autism disorder, which we studied in 2009 to 2014 to see the various dimensions of sensory processing impairment, materia medica, and repertory. Now, all of us know about autism. I need not tell you. When I prepared this slide a couple of years back, the occurrence was 1 in 160. Now, with the latest epidemiological study from US, it has gone to 1 is to 60. The incidences are much, much higher in US, but at the same time, you see the incidences in our country have also gone up in a phenomenal way. The incidence was 1 in 1,000 when we started working with autism 3 decades back. And over a period of time now, you can see phenomenal epidemiological exponential growth. There are a number of factors which can, give rise to this. It's a multifactorial phenomena. When we try to appreciate the causes, genetic factors is one of the most important component. You have got direct factors, indirect factors, and both determine the genetic load which will be responsible in building up these cases. When we say direct genetic factors, I mean the the impact in DNA, impact on the gene. You may have fragile X, or you may have a number of uh, disorders at a genetic level, which can be documented through karyotype as well as genome sequencing. Apart from this, there can be number of although your karyotype may not show anomaly, but still you can see genetic load, and that can be visible through family history. There can be strong family history, either in the sibling having autism or ADHD or neurodevelopmental disorder, or there could be cousins. Now, all these will determine the genetic load. Another strong genetic load which you have identified is family history of OCD or schizophrenia or other genetic neurodevelopmental disorders. That also comes up. So this constitutes a major etiological factor. Now, apart from that, of course, in 16% of cases, we identified mother state during pregnancy, which had tremendous emotional disturbances ranging from phobia, insecurity to depression. Now, this family history also we could correlate and could be contributed as one of the important etiological factors. And third is, which is linked with genetic, is metabolic dysfunctions. And in metabolic disorders, you come across number of metabolic disturbances, a number of biochemical anomalies which could be responsible. Now, all these things I cannot take up in this short time, but I'm just giving you an overview. And vaccine is another factor which we saw in 15% of cases, but we need still much stronger data to really correlate and to make vaccine responsible in a huge way for genesis and maintenance of autism spectrum disorder. Now, this is something which is very important. Lack of spontaneous seeking to share, enjoyment, interest, achievement, non responsive verbal cues, treating people as inanimate objects. Now, these are the most painful features because almost 50% of autistic children, which we have seen, is that they start their journey of life with smile and they are developing well. What happens later? Suddenly, after the age of 12, 13 months, maybe around 15, 16 months, you see regression taking place. The child who was saying mama, papa, child who was giving a wonderful smile and eye contact suddenly starts regressing. The child who used to enjoy the company of elders as well as youngers suddenly becomes aloof. So this is known as regression taking place in these children, and this is the most painful moment for the parents because one who is apple of people's eye. And now what happened? Now this kind of regression makes them extremely unhappy, and then the plight of the parents begin. And so this happened in this particular. In briefly, I'll share this interesting case which came in 2003. So you have 22 years of follow-up observation of this boy who came with me at the age of 7, lack of concentration, poor writing, extremely restlessness, impulsivity, stubbornness, prefers to be alone. Now, you can see a lot of features of ADHD, features of autism. So, ADHD can be strongly associated as comorbidity in autism spectrum disorder. This boy came from Gujarati family. Mother was a homemaker, and they came from a very well-to-do family. And this boy came in the family after years. So he was, taken care very well in pots. Excessive. Parents were worried because now child was showing indecent behavior. He will move round and round in the circle, even during function at home. He will push others, careless about his dress, casual. There's a function in the house, and the boy will start jump in the middle when people are sitting and will make this indecent behavior. He used to pass stool in pants and keeps on touching genitals. Now, these are the features which developed later. He had gained control over urine and stool, but he lost it. So, that initially good behavior, then significant worsening, and then there was this worsening took place around 2 years of age, and there was marked worsening after brother's birth, 3.5 years. He was first child in joint family, over pampered, milk given when water demanded. This is the phrase which is used colloquially to describe the kind of pampering which took place in this boy. But suddenly, what happened that after around 2 years age, there was marked regression, and then when he was 3.5, the sibling was born, and after that, he lost total control over urine and stool, and he started screaming, shouting, and the speech also deteriorated substantially, significantly. No significant past history, family history, osteoarthritis, rheumatoid arthritis, and ulcerative colitis in the family. Now we can see a strong sibling jealousy, and there was marked regression. After that, we can see the temporal relationship, so we can raise it at a causative level. Rest of the thing like restlessness, screaming, this and that belong to autism as well as ADHD. But this precipitating factor as well as the dispositional factor becomes most important. 200 and aphorism 211, it is the state of the disposition which determines the similarity. So when you look up that, it will help you to develop the similarity. So the drug was obvious, hyoscyamus was given. We gave hyoscyamus 200. Gradually there was some improvement in after 3 months only. 3 months there was no significant change, and then there was improvement when we started giving it daily. And then by June there was sleep was better, violence improved, involuntary stool improved, genital handling improved. We gave placebo, and then on 10th July there was aggravation of various functional features, so we gave hyoscyamus 1. Then in the August, there was maculopapular rashes, extremities and trunk. This is classical exteriorization. Herring's glow is proving this is a placebo. Performance much better. This is now 2004. We have come to. We have treated them for a year and a half, and you can see the scores have improved. The performance has improved. What is more important is earlier he used to push others. He would no, he would never feel bad about it. He has pushed someone and someone sustained injury, but now he realizes his mistakes. If by chance he would uh, you know push others or hurt others, he will say sorry immediately. He was curious, now he was creative. So curiosity coming up, creativity coming up, which are the most important aspect. Earlier in the slide we saw lack of spontaneity, lack of creativity. Now that is getting restored, and child is now moving ahead in the developmental zone. We carried out psychological assessment, and the IQ was fantastic, as you can see. This was in 2008. Till 2008, the treatment was intermittent, not much. But the child was in touch, and we had asked him to get monitored. So we used to carry out, we have a multidisciplinary team, we have a clinical psychologist who helps us in a scientific way to carry out all these aspects. Now came the preteen age, and here is the phase wherein the child showed certain defiance, certain aggression. We reviewed the case. Naxomika was given. And again, he came out of that phase of Naxomika. He was doing very well. Then the competitive exams came, and during that exam of his 12th, he came down again with certain difficulties. He came down with tantrums. He came down with irritability, and there was a possibility that he may withdraw from exam. So parents came rushing. They came to me after a long period of time. I evaluated. I also carried out psychoeducational work. There was no trace of autism. Our clinical psychologist found, nor we found. There was no trace of ADHD, but we did find some perceptual difficulties which resulted into difficulties in language. We counseled the child, we reviewed the whole case, and then the natramur was given. The disposition was crystal clear, and the boy responded so well. And in about 3 to 4 months' time, he came out with flying colors from his competitive exams, and then it disappeared forever. But remember well, the sequence of indicated medicines are most important. Organon is most important. Never forget that. There are no third drug. We have treated hundreds of autistic children. 1,000 figure has been crossed. But I will not tell you that there are 1, 2, 3, 4, 5, 10 specifics. No. Please don't seek for it. Please adhere to organon. Adhere to the wonderful triangle the Kant has taught us. The materia medica repertory on the top with a foundation of organon at the base. And it is this triangle which will help you to unlock each and every difficult case of neurodevelopmental disability. So the sequence of indicated medicines, why should I come? Because of the susceptibility. You see, you're prescribing similimum, whether you are prescribing hyoscyamus or noxomica or stramonium or medorinum or natramute, they are all similimum based on the law of similars, based on the appreciation of the totality as perceived through the multidimensional portrait. So it will have tremendous depth. And this totality will work at both the level, at the level of reactivity as well as at the level of sensitivity. And that is how you will see the larger and larger picture emerging. And this will demand a multi-dimensional perceiving again. Very interesting. On 3rd August 2019, after several years, I suddenly received a WhatsApp message from mother. Mother said that my son got his dual degree with very good CGPA. He complete B Farm and MBA. Mother was overjoyed. I have just presented to you the screenshot of this WhatsApp. Mother writes, thank you very much. તમારા કારણે જ મારું ડ્રીમ સાચું થઈ શક્યું. Because of you, I could realize my dream. He got placement from college campus in Pune in good company. Thank you very much. You see the words coming from mother's heart. I responded, great, glad to know this. Hearty congratulations to Abhi and proud parents. The mother writes again, thank you so much. You are the pillar for his success. I am not the pillar. We are not the pillars. Our wonderful homeopathic science is the pillar. Our masters are the pillars who laid down the foundation. We are so fortunate. And we just tread on the path which they have laid down for us, and we see this. And you can see the transformation of the life. Friends, we don't have much time, but I'm just sharing this aside. You have to be with this mother, you have to be with these parents, you have to be with the teachers. Remember, this hasn't come up suddenly. It has come up after the toil of homeopaths, after the toil of parents first, and then acceptance of those parents by homeopathic physicians. Then the multidisciplinary team, the psychologists, the therapists, the educators, all were telling earlier that, sir, we can't handle this boy, do something. He was 7 years, he was in one of the best therapy center, he was receiving best education, but no avail because of the hyperactivity, because of the kind of psychopathology, because of all these aspects. Now, it is homeopathic tiny pills which brought about these changes, and then simultaneously our counseling, our support, our interaction with the multidisciplinary team together, and then we could move ahead. Number of time it has happened that the child is improving but still hyper. The behavioral issues will take time. The speech will take time to come back, and the school will become restless, and they will shout at the parents that take away your boy. We cannot do much. We have shown enough of patience. Then finally we had to step in. We went there with all humbleness and gratitude towards the principal and teachers and explained them, counseled them that look, your little more support for 6 more months will change the life of this boy. If you reject this boy and the boy disappears from your school and goes to special school, the life will be ruined. We went, we explained, and the teacher and the principal grudgingly accepted us, And then within 3 months, there was change. They were happy, and the child continued in the school. And then we can see fantastic result over a period of time. Result doesn't come overnight, my friends. It needs toil for years together. The sweat and blood it demands from us all. And then it is important. So, friends, now quite often I get disappointed when I see that autism, ADHD, doctors are opening up shop. When patient enters, they look at the pocket. No, that's wrong. You are destroying yourself, you are destroying science, and you are destroying the divine child, the Divya. Please be careful. Remain adhered to the ethos, to the values, to the compassion, and what our master said, the higher purpose of living. This is not bakwas. If you remain adhered to that, you will 100% flourish all around. So there are a number of cases and cases. I will conclude in 5 minutes with summarizing our research, scientific summary published in number of scientific journals and has been appreciated by a number of neurologists, psychiatrists, pediatric neurologists, and psychologists. Effectiveness of homeopathic therapeutics in the management of childhood autism disorder. We observed these children before intervention, and when the observation period started, the ATEC autism treatment evaluation checklist score was 72, which went to 79. The children were receiving therapy, education, etc., etc., but they had serious behavioral and sensory issues. So when we started intervention, 79 was the mean ATEC. And after our intervention, in a year's time, we could see that how it went down to 70, and in a year and a half, we could see how it went down to 64. So there is significant difference in ATC score 6 months prior to homeopathic treatment, and at the start of homeopathic treatment, mean value was minus 6.75. That means the ATC had gone up. Higher the ATC, higher the autism, while the mean percentage change was minus 9.83. Thus, we can see that there is significant change after introduction of homeopathy. Mean percentage change jumped to 19.72. It became lower by 19.72, so it was statistically significant. ATC component also show a marked change. The quarter-wise, in the first quarter, we saw 34% improvement in the ATC. Now, this is most important. Autism Research Institute of America has mentioned very clearly that if you introduce any new therapeutic modality and if you want to judge its efficacy, and if in the first quarter, if you see significantly higher change, then the credit goes to that therapy. And what is that therapy? Homeopathy. We can see autistic features improving over a period of time. Now, when we started, the number of cases mild autism was 24, moderate 27, severe 8, and dull normal, that is high functioning, 19. Now, you can see in all these, there is statistically significant change. P-value 0.0001 indicates that there is marked statistically significant change in all the categories. Outcome, you can see that 3.33% showed worsening, 8.33 showed status quo, while 25% showed mild improvement in the range of 15 to 10%, while moderate improvement in 35%, and marked improvement we can see in 26.67%. So from all the statistical parameters, our study outcome showed significant change. Now, what are the remedies which came up in 60 cases? Just for your information, then you can forget this slide. As I said, organon is the final authority which will tell you how to treat. Carcinosin came to 18 cases, stramonium in 7, nux vomica in 5, hyoscyamus in 1, TUB in 4. And in number of cases, we can see first prescription, second prescription, and third prescription. Then only we could achieve the cure. Now, all this material, all these slides are available in number of uh, uh, journal, peer-reviewed research journal. You can study them. If you want link, you can write to me. We will send you the link. We can send you the article. But friends, in nutshell, I can tell you that we can divide autism spectrum disorder. The presentation which comes to us can be kinetic, can be sensory, can be regressive, and based on that, we can see number of drugs coming up, and then we can initiate the treatment through that. What improvement can we expect in autistic child after receiving homeopathic treatment? When child starts responding to homeopathic medication, improvement is first seen at a general level, starts getting calmer, improvement is seen in sleep, appetite, bowel habits. Next in the behavior, reduction in hyperactivity, restlessness, then the eye contact, then communication. Obsessive behavior takes long time to improve in these cases. What factors determine the response? Best results are seen when we start the treatment at the earliest, as soon as possible. Improvement also seen depends on the degree of autism, mild, moderate, severe. That is why our clinical psychologist will help you in documenting that what is the degree of autism and other associated comorbidities, epilepsy, genetic disorder, OCD, etc., will also determine the prognosis and the outcome. So please remember that autism spectrum disorder is a spectrum, variation in intensity, symptom complex, and you need to individualize your each and every case. Thank you, friends. Thank you, Priti, Prajakta, and all the members of this wonderful forum. I congratulate you all for making up this good academic forum, Tamasoma Jyotirgamaya. It is always such forum which brings the light and which is essential, as Hanuman has said, knowledge is. And we enrich our knowledges through sharing of these experiences. And my all the best wishes to you all. Thank you.
Thank you, sir, so much for sharing your cases. Listening to you is always an inspiration and so much of knowledge. So, thank you for coming here, sharing your experience, and we look forward to meet you again on this platform. So, thank you for accepting our invitation.
Thank you.
Yeah, Taskin, over to you.
Thank you, sir. Thank you for joining.
Thank you. Okay. Thank you all.
Yeah, so I would like to invite the we have with us Ashwini Deshpande, a clinical psychologist. If she can come forward and share some of her insights into how to manage the neurodevelopmental disorder cases.
Welcome, Ashwini, and so nice to see you here and looking forward to learn from you.
You are on mute, Ashwini. Can you try again? One?
Yeah.
Yeah.
Can you all hear me? Hi.
Yes. Yes. Hi.
Good afternoon, everybody. And it is a pleasure to be a part of this platform. I'm Ashwini Deshpande Nagarhalli. I'm a clinical psychologist from Little Pods, Mumbai. And we are extremely glad to collaborate with Healing Harmony on this initiative. And we are glad to be part of this initiative. And we hope to give everyone and have ourselves, we had a wonderful learning experience so far. Okay, I think I will just start my presentation. One minute. Just a second, there is some glitch. Yes, can you all see my slides?
Yes, yes, we can.
Yes. Okay. Okay, can you all hear me?
Yes, yes, we can.
Okay, fine. I was just checking if the slides are moving. Okay, thank you so much for patiently waiting. Typically, I guess we've been talking a lot about neurodevelopmental disorders since the start of this session, and Dr. Preeti and Dr. Praful have walked us through different kind of issues that we examine, we understand as part of neurodevelopmental disorders, and how there are several groups of disorders that we are trying to address, whether it is autism, whether it is ADHD, whether there are learning disorders, there are intellectual disabilities, and a number of other genetic syndromes as well, which get categorized into the neurodevelopmental disorders. So I would not get into details of every disorder. I have chosen to speak more about the autism spectrum disorder because it is considered to be one of the most complicated neurodevelopmental disorder, and also a condition where, even though the condition is understood to be a lifelong condition, but there are differences in profile, there are differences in individuals, and the kind of response individuals have to various therapies, treatments in the course of coping with autism is something that is phenomenal, and you cannot replicate or you cannot duplicate from client to client. Right? So talking about the diagnostic systems, I'm sure everybody on this forum is aware that when it comes to classifying and understanding and diagnosing disorders, particularly the neurodevelopmental disorders, there is a DSM-5 or an ICD-11 classification approach that is followed. And particularly the DSM-5 has revolutionized its understanding, comprehension, and uh, basically the whole layout in which we have autism spectrum disorder today is very different from how we understood it some time back, right? So these differences in profile, the comorbid issues, and various aspects or various behaviors that come up from time to time, how do we categorize and how do we understand the relevance of each of them to autism is something that I am sure as homeopaths, all of y'all are dealing with, and all of y'all have some kind of experience in understanding that the manifestation of problems is not just in socialization or communication, or typically the way people would say, oh, the child doesn't make eye contact, oh, he definitely has autism. There are several other aspects to the diagnosis. There are several behaviors to be considered before we confirm the diagnosis. And also there are several developmental areas to be dissected and understood the way they are. vis-a-vis the trajectory, developmental trajectory that the child is currently showing when the child comes over for an examination, right? Followed up with the differences in profile, I will quickly discuss certain management strategies which are also like the go-to strategies, and which, as whether it is a homeopath doctor, whether it is a counselor, whether it is anybody working with children with autism, needs to have somewhere at the top of their minds, because these are some of the do's. Like, you really cannot mess with these. And if you are working especially in empowering, because homeopathy believes a lot in empowering the family, empowering the parent, and also helping the healing process of the family, right? This is a good idea. It is always good to have these things as a checklist in your mind, because they will help you reflect on, are these aspects getting covered with the child or not? Followed by, I would like to share certain experiences with the kids that we are working with the kind of services we are giving to these kids, and what is the impact or the quality of life that they are experiencing currently. Yes. So moving on, I guess everybody is aware about the very etymology of the word autism. Autism, the word in itself means in your own world, right? So when we understand the child, or when we understand autism as a parallel personality, the way we start classifying autism as a neurotypical personality, right? Is it is easier to explain to the parents, it is easier to explain to the family, it is easier to explain to the caregivers in terms of why exactly this word is being used as a diagnostic label with the child, right? So instead of complaining that the child doesn't interact, the child doesn't talk, the child doesn't make eye contact, it is simplified in terms of one term called autism. Of course, that doesn't limit the child's abilities, but it is also an important characteristic of diagnosis, because the lack of socialization skills, the need to stay in their own world, the need to be in their own world, as we say, is something which is very marked. And somewhere this behavior or this notion is often understood as somebody being an introvert, or somebody not really wanting to socialize, or somebody being on the quiet side, being shy. However, it is our responsibility as health practitioners that we understand the whole behavioral approach of autism in framework of the autism spectrum disorder, and help the family or help the caregivers in understanding what exactly is autism spectrum disorder, right? So coming from the umbrella term of autism, previously there were separate disorders that we knew of. There was something called mild, moderate, severe autism. There was something called Asperger's. There was something called childhood disintegrative disorder and Rett's disorder, which were the typically regression-oriented disorders, where there was a lot of loss of acquired skills on part of the children. However, all of these have been clubbed under one umbrella term called autism spectrum disorder. Often we come across reports of kids, or often we come across therapists or people referring to the child as having social communication disorder, right? Social communication disorder is nothing but a variant of autism spectrum disorder. Previously, it was often referred to as pervasive developmental disorder, not otherwise specified. However, now for the working diagnosis purpose, or for the ease of communication, a lot of therapists have switched to this term using social communication disorder. All right. Okay. An important aspect to the current diagnostic system is not just understanding autism in terms of mild, moderate, and severe, but it is also to understand the level of independence that the child has, right? So the DSM-5 specifically talks about the 3-level functioning of the child, which helps in understanding what is the capability of the child, what is the functional capability of the child, where is the child, and what is the developmental milestone that we are looking at where the child is stuck. All right. So somewhere where we look at level 1 as the high functioning autism, which is also commonly referred as Asperger's syndrome, right? These are the individuals who somewhere may or they do not require support, but the kind of support they require is very superficial, right? So when I say superficial, it is just an adult who needs to supervise or, who needs to make sure that the child is doing fine. Other than that, when it comes to their self-care needs, their needs to eat themselves, when it comes to understanding their own schedule, understanding their own routines, they are very independent, and they are also somewhere aware of the kind of things that they are supposed to do. However, the kind of issues or the kind of weakness that we see in their profile is somewhere where definitely they lack the ability to initiate social interactions. There is a lot of inflexibility in their behaviors that you will see. For example, if the father had said that, okay, today is Friday and we are going to have pizza tonight, right? Come what may, the father has to bring home a pizza, otherwise the child is having a meltdown. The reason being, for whatever reason, the father got late from the office, or for any reason, if the pizza could not reach home, the child will not accept this kind of change in routine or change in the pre-decided program, right? So this inflexibility of behavior could pose certain issues and challenges at their own level, whether it is at home, in a social setup, or even in an academic setup, followed by difficulty in switching activities. So if the child is used to doing things in an XYZ sequence, then the sequence of doing it is extremely important. The moment somebody upsets that sequence, the child could have a meltdown, or the child could be, the child could feel that the world is crumbling and there is a complete chaos around him, right? So problems with organization, however independent the child is, the child will struggle to remain organized, keep his or her own things in place, take care of things. Okay. Often there are individuals who are also on the other extreme of being extremely organized, and they want to put things back in their place immediately, but overall inability to manage their own time, somewhere struggling to understand what task to approach first, what next, is something that is common across different profiles of autism. Moving on, the level 2, which requires a little more support, right? So here they will even require support in terms of coping with change and any kind of distress that comes in. That is also definitely going to bring in a lot of help and support from the family and caregivers, right? Also, the level 2 autism, when I talk about the academic profile of level 1 and level 2, a level 1 child with autism is somebody who will have good cognitive capabilities, will be doing quite well at academics. It is only until the higher grades is where the child may require some kind of support or help. Whereas when I talk about level 2, of course, they require a lot of one-on-one mentoring, a lot of creative and unconventional methods to learn and understand the academic content as well. Okay. As we move on, the level 3 or the severe autism that we always knew of, this profile definitely has a lot of other comorbidities. Other than requiring support, they also require instructions for every task. Talking about the verbal ability of all these 3 levels of autism, the level 1 and level 2 could be selectively verbal. Level 1 could have normal speech. There could be a history of delayed speech as a milestone, but eventually the child has caught up and can speak well, can communicate well. However, when we talk about level 2, a lot of speech therapy has further aided speech and communication training in the child. And that's where the child is able to respond to his environment and communicate with people around his environment, right? Whereas when we talk about level 3, they could have selective mutism, they could be non-verbal, or they could learn a basic communication, need-based communication only after a lot of effort through speech therapy. And these days, often with the help of an alternative augmentative communication device, which we call as the AAC device, where the assisted device is helping you communicate and respond to people in your environment, where on the tab you press certain keys, and the communication is voiced in articulated in terms of I want food, I want water, I want to go down to play, starting with those basic need-based activities. Okay, I am not getting into the details of the brain areas, but of course, an important aspect to understand is the atypical organization in the brain is also one of the reasons which has hampered normal course of development in an individual or in a child with autism. And as a result of this atypical organization, the different areas, the functional areas of brain are further manifesting challenges for the child over the course of normal development, right? So whether it is emotions, whether it is the amygdala, which is triggering the emotions and the aggressive behaviors, or whether it is hippocampus, which makes learning of new information difficult, it is as a result of these brain structures and a suggested anomaly or a suggested neural circuitry which is affected in these areas responsible in a separate presentation of their developmental abilities. Okay, when we talk about the autism spectrum disorder or autism as a personality, right? We are trying to understand the several aspects of behavior and cognition, where the behaviors are manifesting differently in a neurotypical child and in a child where we are expecting certain developmental milestones to be achieved at a certain age. For example, sensory processing is an important, very important diagnostic criteria as well as a behavioral observation criteria, because sensory processing issues are the earliest to manifest, and the child's sensory profile, where there is a discomfort in terms of hypersensitivity or hyposensitivity to the 7 basic senses like sound, vision, tactile stimulation, exploration of the environment. A lot of these vestibular inputs, proprioceptive inputs, are challenged as a result of a sensory processing disorder. And sensory processing disorder is comorbid with autism spectrum in most of the cases, and they are primary challenges and concerns when it comes to the child's early learning and developmental milestones achievement. So followed by sensory processing, of course, there are repetitive behaviors. That is another criteria of understanding and observing autism-related behaviors. When we talk about repetitive behaviors, we are not only talking about restricted and limited interests, but we are also talking about repetitive interest in certain games, activities, sequence of events, small behaviors like lining up, and the child trying to get fascinated with certain objects and carry them around all the time. Like it could be a stick, it could be a stone. The child's insistence on using something in exactly the same way he or she wants. That is also one of the primary feature of repetitive behaviors and a very core symptom of autism spectrum. Of course, there is motor skills. When we talk about motor skills, we are not only talking about the involuntary motor movements, but because of the milestone delays in certain gross motor and fine motor milestones, there are also certain motor skills which are affected, due to which the child could have gait related issues, the child could have posture related issues, the child could require certain correction of reflexes, the primitive reflexes, which is often addressed by a physiotherapist and an occupational therapist. Other than these primitive reflexes, there could be a lot of compensatory muscular behaviors where the muscle tone is either suppressed or it is expressed beyond necessary. So the optimum understanding of the child's motor skills and motor behaviors is also crucial in knowing why the child behaves in a certain way and why there are certain behaviors which lead to the child functioning in a certain way, right? Along with that, we also talk about the involuntary motor skills, involuntary motor behaviors or the stereotype movements, which could be something like rocking, hand flapping. These involuntary movements are also referred to as stimming behaviors, which we observe in children with autism. Stimming is any kind of repetition, and particularly the stimming behaviors or these involuntary behaviors have a very core function. So often the child will engage in more of these behaviors, when he or she is unable to regulate himself, okay? Other than regulation, when he or she feels threatened or when he or she feels overwhelmed in a specific environment, that is when some of these stimming or involuntary stereotype movements could also be seen. There could also be a chance where the child is emotionally trying to connect or communicate and feels that the object of emotion or the object of object that can help the child regulate his sensory needs is not available in the immediate vicinity. Like, right, like for example, if the child is used to hugging the mother or hugging a pillow and the child feels that I don't find my pillow or I can't see my mom, and that is making me anxious and overwhelmed, and that is further leading to some kind of stereotype movements or any of these motor stimming behaviors, followed by the perseverative thinking. So often, and I think in the cases that were discussed previously, one of the aspect that was also covered was the child's ability to repeat and ask certain questions, or rather, the child trying to ask, "Kab jayenge? Nani ke ghar kab jayenge?" The child knows we will go in the evening, but still, "Kab jayenge? Kab jayenge?" Some of these repetitions, or the way we say as echolalia, are important aspects of not only the perseverative thinking capacity of the child, but also the verbal and non-verbal communication limitations, right? So when we talk about perseverative thinking, it is the child's inability to shift his mindset from one aspect to the other. So in very simple academic terms, if the child was doing two sums of addition and you give a third sum of subtraction to the child will continue to add and not subtract. Why? Because the child is struggling to shift his focus and attention or his attentional capacities to a change in concept, and that is leading to this kind of perseverative thinking where the child is constantly associating something else to something that is no more existing, right? So it could even be in terms of the child randomly saying, "Udhar mat jao, gir jaoge." The child is sitting in a classroom and the child shouts, "Udhar mat jao, gir jaoge." So where is this coming from? Probably the child is reliving a scenario in his head where probably he was playing in the park the previous day and somebody, maybe the mother or somebody, told him, "Udhar mat jao, gir jaoge." And the child has somewhat associated those words, those statements, and remembered them and has applied it to this scenario in the class. right? So these perseverative thinking errors is where often the parents will say, कभी भी कुछ भी बोलता है, किसी चीज का सही आंसर नहीं देता है. Or, you ask a question to the child will give some other response. That is where the child is unable to shift to an appropriate response because the previous thought process or the previous concept has not moved out of his head. Connecting back to again verbal and non-verbal communication, we are talking more in terms of the echolalia and repetition that we understand the child has from time to time. And echolalia is nothing but repeating of the last heard words. And it has a very specific function because often it needs to be viewed as a self-reminder that the child is giving to himself or herself to remain grounded. Right? If the child cannot figure out what to do next, the child will say, "Ghar jayenge, ghar jayenge, ghar jayenge." The child has probably asked, the mother has said, "Okay, iske baad ghar jayenge." The child will keep repeating, "Ghar jayenge," for the mere clarity of what is going to happen next. If they cannot predict, the need to predict or need to know the next set of events is very crucial for children on the autism spectrum, because for them that is the only way they understand or they can make sense of their environment. Other than that, it is very difficult for them to remain connected to their environment or understand their purpose in a specific environment. So I have connected to the social awareness and of course information processing. The rate at which they are processing information is definitely slower than other individuals, and that is where the information processing requires time. So you can understand the information processing ability of the child equivalent to your phone or laptops which are running on older processors, and because your phone is out of storage and there is too much content on it, the phone is taking some time. The moment you click an option, it takes a while to respond back. So that is a very typical presentation in these children. And often we train and we tell the therapists and we tell the parents that don't keep repeating information simultaneously. Allow the child to process an instruction, act on it, and maybe then you supplement it further. Okay, a quick overlap with the other disorders. I think the image is more or less self-explanatory, but there are several other conditions where, certain behaviors or certain aspects could be overlapping. As I also understand in the detailed case history taking method of homeopathy also, where a clinician is also trying to place what is happening at the behavioral level, what is happening at the cognitive level, and further what is happening at the emotional level. Is there some form of social anxiety? Is there some form of generalized anxiety? Along with it, what comes in is the sensory processing profile, which is very crucial to the diagnosis of autism spectrum disorder and the sensory processing concern, because the sensory processing issues will never be the same, right? So today, if the child is bothered more by an auditory, if the child has more of auditory hypersensitivity, right? There is a good chance over the period of time, the child will be comfortable with a certain level of auditory sensitivity. And that has now moved further to a maybe tactile or a vestibular sensory need for the child, right? Hence, the sensory profile of the child, because of the delays in development, is constantly evolving. And because of those, there could be a lot of avoidance and resistance-oriented behaviors. And that is something which will determine the severity at any given point of time. Because often when children come for diagnosis, when they come for evaluation, their sensory profile is elevated where a number of areas require attention. And gradually with interventions, with therapies, a number of these areas have started settling down. The child starts feeling comfortable. The child is learning coping skills. So if there were 5 sensory areas before which were of a concern, it could pretty much go down to 2. Okay, very typical diagnostic team. I'm sure everybody is aware. Often the diagnosis comes from the school, from the family doctor, and eventually a pediatrician, the psychologist. And there is a team which becomes involved because there are sensory concerns to be addressed. There are speech and communication issues. There are academic and behavior challenges which need to be addressed. So all in all, we have been speaking about the teamwork. So I will not elaborate further here. Okay, a quick input from the clinical psychologist's desk is the kind of tools that we engage when it comes to assessment procedures, right? So often when we talk about ASD diagnosis, we are definitely trying to understand the severity of ASD, but there are also IQ and other related areas which have to be looked into. However, when we talk about IQ, it is very difficult to assess when it comes to a child on the autism spectrum, and especially in the early years, because the child's communication strategies, the child's teaching learning response, the child's behavior issues are too many to actually manifest the cognitive ability of the child, and for us to have a good indicator in terms of what is the capability of the child. Hence, it is always kept on hold, or rather it is assessed based on the verbal or the non-verbal communication modality of the child. If the child is verbal, then a detailed evaluation can be conducted, and an IQ assessment can be attempted. However, there is always a word of caution when it comes to interpretation of IQ, because whatever IQ score we get most of the time in the autism spectrum disorder may not be the true indicator of their IQ. And there is always a good potential that the IQ ranges will show some changes because of the other therapies that the child is undergoing. Like once the sensory profile of the child is better, the child is better regulated, the child has learned certain occupational skills, the child's fine motor skills has improved. So his performance on the performance test of intelligence will automatically reflect a change. And all of these will eventually show a change in IQ score only because the original skill set has evolved and developed for good. However, when we talk about the younger age group, the checklist that we most often use is the modified checklist for autism in toddlers, which is called the MCHAT. And there are very specific toddler behaviors which the MCHAT is trying to understand, and a score of more than 3 is suggestive of, again, it is a screening tool and it is not a diagnostic tool. So it is suggestive of traits of autism, and hence a further follow-up or a further evaluation after starting therapies is recommended to parents based on the basic MCHAT screening. CARS is the childhood autism rating scale, where a number of sensory and behavioral areas are observed and evaluated by the clinician. So the psychologist will exactly ask the parents that, okay, how is he with relating to people or communication skills? How is he in using play items or objects that are lying around? Do you see a very different pattern of him getting obsessed with certain aspects of the play or certain parts of the toys? So it is a detailed interview schedule and also certain observations to be made parallelly along with the conversation with the parent, and that gives a score on CARS. A score of less than 30 is considered as a non-autistic category. However, often individuals who've received intensive therapies and interventions in their early years later on also end up showing less than 30 score on CARS. But we often interpret with caution because autism is not something that will just go away overnight, right? There could be certain traits in the personality, in the social communication skill, in their emotional regulation skills, which may sustain even though they do not reflect 100% on the CARS at a later point of time. Another popular tool is ISA, which is the Indian Scale of Assessment of Autism. It is a tool which assesses the disability of the child based on the autism score that he or she gets. And it is often used in the government setups, especially for certification purposes. And often a lot of children with multiple disabilities are also assessed on ISA to check certain markers for autism. Along with IQ, there is an important assessment of ADHD and VSMS, because most of the children who have a sensory processing concern where they are hyperactive, there is a lot of vestibular input that they need, they will definitely require some kind of ADHD assessment to understand the nature of hyperactivity. And VSMS is a tool that we use to assess the adaptive behavior skills. When we talk about adaptive behavior skills, it simply implies to the child's ability to care for himself or herself. So when we talk about the self-care, self-help skills for eating, self-help skills for dressing, self-help skills to understand what belongs to me, this is where my house is, how do I find my way back, a little bit of self-direction, communication, is there any kind of meaningful engagement and occupation? All these areas are assessed versus the are assessed with the developmental age of the child, that at this age, where should the child be? Collaborating further with the comprehensive intervention approach, if the child has received a diagnosis early on and there is early identification, then there's nothing like it. The child is definitely showing remarked progress because of the comprehensive intervention approach. So whether we talk about the medication, which could be through allopathy, through Ayurvedic, through homeopathy, there is speech therapy and communication training working with the child, the occupation therapy and sensory integration, behavior modification, counseling, parent training, and the academic support in terms of either homeschooling or some form of remedial skills is all coming together for the child to develop and show an all-round progress. A quick rundown of the management strategies. As clinicians, when you all are interacting with the parent, we always suggest that, make sure that the parent, of course, requires a lot of support in understanding, because there's a lot of denial in the initial phase. So understanding and accepting autism as a concern. So knowing what is autism, what is part of autism, what are the behaviors which are part of autism, which you cannot directly target to change, and what are the behaviors which will be somewhat, capable of undergoing some kind of behavior modification. That has to be differentiated in the counseling or the parent training session. So when we talk about the verbal communication, what is the communication style of the parent? What is the instructional approach? Is the parent not allowing enough processing time, giving instruction, rushing the child all the time? Right? So in that case, the child will anyway struggle to keep up with the auditory processing skills, and will also struggle in following up with the actions. Then always refer the child on first name, first person basis. Help the child understand what is the second person approach, because the whole difference between I, you, we, me is something that the child is constantly struggling in his social pragmatic communication skills. So working on that is a major goal for speech therapists or the ones who are doing communication training. But even at home or as a professional, you can observe what is happening with the child. Always refer to the child by his name to call for attention. Insist initially, if the child is non-verbal and not picking up on a lot of speech and verbal skills, insist on use of one language with a basic vocabulary. Use very short phrases or sentences. Do not engage in elaborate long sentences. If the child has done wrong, often in the zone of punishing the child or in the zone of scolding the child, we all end up using long sentences, right? So that is definitely something which is not working for the child. As I mentioned earlier, use of alternative and augmentative communication devices. So for individuals with autism who are now 10, 11 years old, but have still not developed any form of speech, with them, it is always a good idea to help them with an assisted device like AAC device. It can be a regular tablet with any of these apps. There are a number of apps. However, Avaz or Jello are the most popular ones that we are using in India. And the speech therapist will also train the family and the child to engage into communication with the help of the device. Visual supports for routine. So most of the kids who are on the spectrum have a very high visual sensory demand, right? So they can process information better when it is visually provided to them. So it is just as simple as, often if as a kid somebody learned to make Maggie, they saw the images behind the pack of Maggie where it showed you are opening the noodles, you're putting the taste maker, and you're bringing everything everything to a boil as a visual and learned the process. So it is as simple as that for a child on the spectrum. And that is where the demonstration, the icons, the images, the pictures, the visuals matter the most. So visuals, again, arranged in a sequential manner or in a hierarchy, gives a good structure for them to understand what to do first and what to do next. Followed up with a visual schedule or a visual chart to explain what is going to be the logical flow of events. How are they going to proceed throughout the day? Discussing changes, preparing for transitions is something very important. Any kind of change, like for example, from today from school, you're not coming home, you're going to your grandmother's house. You cannot just pick up the child and take to his or her grandmother's house. You have to let the child know in advance. So preparing the child for any kind of change or transition is extremely important. Even before going to a social event, what to expect at that event, what is to be done, or why are we going there, who all are going to be around us, what is the event, all of the explanation has to be given to the child. If possible, visually show a few photographs of people whom the child might meet there. That gives some scope of preparation, and the child will find himself easy to regulate in a social situation. Do not repeat persistently, avoid cluttering or overwhelming. Allow space for the child to calm down, cool down. Carry a calm down box or any kind of object of attachment. As I said, if it's a pillow that the child likes, make sure the child is going with the pillow. If there is a bag that the child wants to carry, let the child go with the bag. Structured reinforcement schedules in terms of when does the child get a reward, when does the child doesn't get a reward, how often can a reward be given, who can give a reward. All these have to be very clearly communicated, discussed, and explained to the parent as part of the behavior modification training, because only then the child will see the consistency and learn and understand which behaviors are to be modified for good. For the children who are constantly on the go, there is a lot of movement, there is a lot of restlessness, hyperactivity. For them, engaging in some form of physical activities or creating systematic movement breaks is very important. So if the parent is constantly comparing, he's not sitting in one place, he's not sitting in one place, it is important to counsel the parent to understand that sitting tolerance has to be developed. And what is the capability of the child? What is the limitation? If he can sit, focus, do something for 2 minutes, focus on giving a shorter task to the child. So giving partial credit, working in a team, understanding what kind of organization skills are important, what kind of visual study skills are important, like diagrams, mind maps. All of this has to be coached to the parent to understand that these are the things which will matter and make a difference. An important aspect, most of the parents, when they come to us, oh, I had to hit my child because he was not listening, he was not doing this, he was not doing that. So punishment and aggression management is also something that has to be addressed. And if you hit, the child will hit back is a simple philosophy that most of them need to be made aware of. We've been speaking a lot about the sensory processing issues. It is important that when the child is having meltdowns, the child is able to regulate himself and not indulge into any kind of self-harming behaviors. If there are self-harming behaviors, if they can be anticipated, proper measures to be taken for that. Do not keep correcting visual stimming or verbal stimming, that don't do this, don't do that, don't do this, don't do that, because that is further going to irritate the child. These are some very quick de-escalation techniques when it comes to what kind of tone do you use, how do you give space to the child to calm down, how do you use a distraction, how do you not ask questions or make demands when the child is having a meltdown. Are there any breathing exercises on which you have worked with the child? Are there any calming visuals that you have worked? Sometimes not doing anything, just let the child be, may also be like the golden principle to managing a meltdown. We have been speaking about academics, but yes, a shadow support program in an inclusive school is something that really helps the kids. Further, focusing on if the child is struggling with the regular mainstream academics, focusing more on functional skills or a modified curriculum where we are teaching important life skills to the child through the use of maths or through the use of certain environment related concepts is required, and this kind of a customized program is something that we definitely work with a number of kids with, and we give them the homeschooling program and we give them a modified curriculum just so that they learn what is important rather than just being fed with the content from the textbook. So always recommend something like that to a parent whenever you feel that the child is not making much progress academically, or there is something in the whole academic paradigm which needs to be reviewed. Avoid getting fixated on a spelling based approach like phonics. Oh, he's not learning spellings through phonics. Maybe the child doesn't know phonics, but you ask the child to spell glad, the child will spell glad, right? Because the child doesn't learn only through the sensory sound system, but also through the visual system. So maybe the spelling as a pattern has registered for the child, and the child has remembered to spell something on a visual mode and not on a auditory mode. Right? So even though the child will have fine motor issues, writing issues, it is important to keep motivating the parent to gradually work on it. Writing comes in for most of the kids, of course, because of the visual perceptual problems, the spacing, font, size, the alignment. Those are for a toss, but definitely if there is a good occupational therapist working with the child, they also focus on these aspects too for correction, and these aspects eventually fall into place for most of them. In cases where there are motor difficulties, it is always good idea to switch to typing. Okay, so coming back to the outcome and the quality of life that we are trying to achieve with these kids, at Little Pods, we are also working with a number of adults with special needs with whom we may have worked as an adolescent, or who have done therapies with other set of therapists and counselors, but have now come to us with a very different approach. So most of these adults with whom we are working have completed some form of formal academic training through NIOS, or they have gone to a mainstream school, finished their 10th grade with accommodations, and they have successfully finished one part of their career and now are looking out for some kind of a creative vocation. When we say creative vocation, these children are always an edge above the others when it comes to certain creative skills, whether it is baking, music, art, it could be dance, it could be anything. So we always encourage the parents that let the child pursue his interest, and let's hone that as a vocation and a career rather than getting fixated only with the academic approach. So it is important to indulge such individuals into some form of life skills training where we are working on coping skills, we are working on vocational skills, and these days the most important thing is digital literacy, which is also part of our skills training program. And most of the children, most of the individuals, or rather adults with whom we are working, have learned very important and optimum life skills where You need a gadget in your day-to-day life, and how do you use? So whether it is to book a cab, whether it is to look up a location on Google Maps, whether it is to order food if you are alone, a lot of these skills are taught as part of the life skills training program. So moving on, definitely this eventually has brought them to understanding their own accomplishments. Oh, I can also do something. And even for the parents, it is a very good realization that, oh, we did not know, we did not think the child will come this far, or we did not think that the child will achieve so much over a period of time, and the child is doing so well with digital literacy and to other aspects of vocational skills, right? Clients with early diagnosis often see a dip in their follow-up assessment. As I mentioned, in terms of the severity, they may show a dip, but because they have started all their interventions early on, whether you talk about the medication, whether you talk about the therapies, the child now has very selective struggles to deal with. It could be very specific areas on which the child requires support over and above the child is learning to become independent or come at par with the other kids of his or her own age. Eventually, when we talk about clients with mild to moderate autism, in our experience or with a lot of kids that we have worked with, most of them, they look forward to academic independence, and they have reached a level of academic independence by the time they go to grade 5, around the age of 10. They are able to manage their basic routine behaviors, their classroom activities, social skills. Social skills, minimally, they can manage. Of course, whenever there are issues of conflicts, there is some adult who has to intervene. But of course, they probably need just help in some of the areas of academics and emotions management. Over and above, they are independent in a number of ways. So when we talk about the quality of life that we are looking at with these individuals, when there is a holistic approach which is practiced, and when there is a team which is working with this kid, it is amazing to the extent to which they can achieve. Like whether we talk about the examples that Dr. Praful mentioned earlier, or whether we talk about the cases that Dr. Preeti also discussed, right? The children do come a long way with the right kind of interventions and the right approach to therapies and management. With this, we cannot ignore the fact that it is constantly on the rise. And as per the National Autism Association fact sheet, 1 in 36 children is the current rate of diagnosis. Boys are 4 times more likely to get diagnosed. And also the 40% of the children with autism do not speak. So we have a bigger burden to shoulder and a bigger responsibility to cater in future when it comes to working with the children with different neurodevelopmental disorders, and especially with autism, which we cannot ignore or we cannot let go in our community. So with that thought in mind, let's join hands to make this as a bigger purpose of our life and help as many individuals as possible in every way that we can. Thank you so much. If there are any questions, we can. Sorry if I took up a lot of time.
Thank you, Ashwini. Very rightly said. We all should join hands and we can collectively and together by our different methodology help these children, especially able children. Thank you so much for sharing your insight. If we have any questions, we'll take moving ahead. You all can write in the chat box if we have any questions. Okay, I see no question. Thank you all for joining. Thank you all for coming and sharing your knowledge. And hopefully we can together help these specially able children. We have a lot of courses on, we have a course on autism, which was taken by Dr. Aradhana Chitra ma'am last year. The recordings are available. We have the ongoing pediatric course that has a 12 session course, which talks about the various management of various pediatric care. So you can just write us on, we've shared the email ID, you can write us and we can share the further details. We have an upcoming course on psychotic disorders with Dr. Pritisha and Dr. Prajakta Vaidya, where for the first 30 participants, we are going to offer 30% discount on this World Homeopathy Day. Do write to us, contact us, and we can surely help you further if you have any questions or queries. We have our website, the link has been shared. You can go on our website. We have a lot of courses and material available on our website that will be helpful for all of you. Thank you all for joining today, and it was a wonderful session. Thank you all. Good evening. There is, I think, one question by Yamini. Any management suggestion for sensory issues?
Okay, so to answer your question, when it comes to sensory issues, of course, there is a proper sensory profiling which is done through an evaluation by an occupational therapist who is also a sensory integration therapist. Okay, so the occupational therapists will typically chart out a profile, sensory profile of the child where, it will clearly mention which are the sensory seeking behaviors or sensory seeking areas and what are the sensory avoiding areas for the child. Following that is where we understand whether it is some kind of accommodation we require on auditory sensory issues where the child finds the classroom too loud or any environment too loud. Do we give the big headphones to the child to cover his ears rather than constantly sitting like this? Or if it is a visual sensory need, then do we give something like a glitter bottle or a bottle with some things moving inside for the child to play around and indulge from time to time? Of course, if there are other vestibular or gravitational insecurity related sensory issues, then the child could be too scared to go on the swings, or the child could be on the swings excessively for the most of the time that he or she is in school, right? So depending on the sensory profile of the child is where some suggestions are made. So I would suggest you connect with an occupational therapist who is working on sensory processing, who can give very specific suggestions for which sensory need, what behaviors or what accommodations to be given to the child.
Thank you so much. I hope that answers your question. Yeah.
Thank you.
Thank you, Ashwini. Thank you again for joining us. Bye. Take care.